All right, thank you so much. Nice to be back here with my good friends, the stars of the vein disease. And talking about the PTS, despite appropriate anticoagulation therapy, about 50% of patients with DVT will develop PTS, like a BCV, and up to 20% of this population. Although it is not possible to foresee the development and course of PTS in individual patient, clinical predictors of PTS are identifiable at the time of acute DVT. How to diagnose PTS? Well, there is no gold standard laboratory imaging or functional test that establish the diagnosis of PTS. Made on clinical grounds based on the presence of typical symptoms and signs in a patient with previous DVT. Symptoms tend to be aggravated by standing or walking and tend to improve with rest and leg elevation. Here is we don't need to go through the Villalta scale, but that's the standard is being used now, but has several issues. For example, it doesn't include venous claudication, right? It would be a major issue. And can a patient have a tiny ulceration? You have to get 15 points as having a tiny ulcer. This doesn't make sense. So for patient evaluation, do the ultrasound and axial imaging, examine all the veins and do a clinical assessment of the lymphatic system. The protocol for the ultrasound, ideally in the standing position, not in the supinal, most people do for post-thrombotic disease. Check for reflux, main emphasis on deep veins, the entire limb, examine superficial veins and perforators in people with skin damage. And then for obstruction, all deep veins, including the iliac and IVC in patients with clinical suspicion. After an episode of DVT, you have obstruction of vein like the popliteal vein here, or you can have, complete recanalization with reflux, or sometimes in this patient, you can have, partial recanalization but no reflux whatsoever. And here is a typical patient. The most common scenario, you have partial recanalization with, different channels of flow, irregular vortex, thick walls, and patients have reflux and obstruction at the same time. And we know now from the paper of Comerot and others that, if you have obstruction, it'll be there for a long time, particularly 6 months, then it's collagen. Important to know because this cannot be removed, the TPA and other methods of, lytics. In our paper here, we demonstrated in 2017 that if you have acute thrombosis, the wall is very smooth and you have an increase in the wall thickness for about 50 to 80%. But in the post-thrombotic disease, you see on the last slide, you see the increase at least 100% or more. And that's the chronic part of the inflammation, something we're studying on our laboratory right now. But other things you have to include is very important. Look, the patient evaluation. The patient, you have to look, is there any musculoskeletal impairment? For example, joint, mobility from ankle, muscle pump performance, such as, having muscle atrophy or injury. And then, of course, the risk factors that we are familiar, recurrent ipsilateral DVT, the characteristics of the initial DVT, the quality of oral coagulation, residual thrombosis on ultrasound, and persistent elevation of the dimer. The distribution and extent of thrombosis is also important. And you see on the left panel, if you have thrombus in one venous segment, it's very unusual to get skin damage. But if you have multiple segments involved, 2 or more, then the frequency of skin damage is much higher. Other risk factors for PTS, including age, elevated body mass index, pre-existing primary CVI, that's not included in most studies of PTS, persistent venous symptoms and signs at 1 month after acute DVT, unprovoked versus secondary does not appear to influence the risk. However, unprovoked DVT has a higher incidence of recurrent DVT. And then, of course, gender and inherited thrombophilia, they have no consistent relationship. Now, that's all important because you can, as my colleagues will tell you later about, how to fix in such patients, you can treat, of course, the superficial and this system with any order the patient presents. Very simply, because I asked to put the classification, this is work done by a good friend here on the panel, Dr. Human Jalai. And this is different five types of obstructions here. Based on the type of obstruction you have different clinical outcomes, with the type 5 having the poorest outcomes. And I think at some point we have to use correct classification and improve on it so we can tell to the patient what's the probability of getting better or not. Right, I'm going to skip this because he's going to talk about it, all his slides. And I'm going to skip this because they told me to finish quickly. So, Mr. Chairman, patients who develop PTS or DVT can be treated with conservative means, supervised exercise program, weight loss, skin care, and in severe cases, evaluate the venous system and treat the underlying pathology. Thank you very much.